Picture this. Someone slices open a leg on broken glass, and within 5 minutes, before help ever arrives, they can bleed to death. For decades we told people the tourniquet was the very last thing you reach for. That advice was wrong, and it's been quietly costing lives. Battlefield medicine changed this. Widespread early tourniquet use cut deaths from uncontrolled limb bleeding by roughly 2/3. That data didn't stay in the military. It rewrote the civilian rulebook too. Today, the tourniquet isn't a desperate last option. It's a first-line tool, right alongside direct pressure, and the sooner you reach for it, the more likely someone walks away. By the end of this video, you'll know exactly when direct pressure is enough, when it's not, and how to put on a tourniquet correctly in under 30 seconds. I'm Arthur. This is First Hour. Let's get into it. Here's the biology that makes this an emergency. An adult carries about 5 liters of blood. Losing roughly 40% of it, around 2 liters, can be fatal, and a severed major artery can lose that in minutes, not hours. Not all bleeding is equal. Arterial blood is under pressure from the heart, so it sprays or spurts in rhythm with a pulse, often bright red. Venous bleeding flows steadily and darker. Arterial bleeding is the kind that kills fastest. Arms and legs carry major vessels close to the surface. The femoral artery in the thigh, the brachial in the arm. A deep cut or puncture near a joint can nick one of these, and pressure alone sometimes can't hold it back. As blood volume drops, the body panics. Heart rate races, skin turns pale and cool, breathing gets fast and shallow, and the person may feel dizzy or confused. That's hemorrhagic shock, and it's the thing a tourniquet is racing to prevent. The first 60 seconds matter more than anything you do after. A fast, imperfect response beats a slow, perfect one. Because for severe bleeding, the clock is the real enemy, not you. So what actually counts as life-threatening bleeding? Blood that's spurting or pulsing, blood that soaks through clothing or a dressing in seconds, a pool of blood forming on the ground, or an amputation or partially amputated limb. Before you touch anything, check the scene. Is there ongoing danger? Traffic, a downed wire, an unstable structure? You can't help anyone if you become the second victim, so move to safety before you act. Call 911 or have someone else call while you start treating the bleeding immediately. If you're alone, put the phone on speaker so your hands stay free to work on the wound. Expose the wound. Cut or tear away clothing so you can actually see the source. You cannot control bleeding you cannot find, and clothing hides both the wound and how bad it really is. For years the guidance was, try direct pressure, try elevation, try pressure points, and only if literally nothing else works, as an absolute last resort, consider a tourniquet. That sequence cost lives. Military trauma surgeons studying combat wounds found that early tourniquet use, before shock even set in, pushed survival rates for major limb bleeding above 90%, compared to near zero, once shock had already taken hold. That evidence moved into civilian medicine fast. The American College of Surgeons built the Stop the Bleed campaign specifically to put this training in the hands of ordinary bystanders, not just paramedics and soldiers. The American Heart Association and Red Cross both updated their first aid guidelines. A tourniquet should be used as soon as it's available for severe limb bleeding that direct pressure isn't controlling, not last. As soon as available. Even the textbook that trains trauma teams as trauma convoded. The SOFS that trains trauma teams, advanced trauma life support, now puts catastrophic bleeding control before airway management in its very first step. Bleeding control moved to the front of the line. None of this means skip direct pressure. For most wounds, firm, steady pressure with a clean cloth or dressing, held without peeking, still stops the bleeding on its own within minutes. Here's the line. If you've held firm pressure and blood is still soaking through, if the wound is spurting despite pressure, or if you simply can't maintain pressure, that's your signal to go straight to a tourniquet. Don't cycle through elevation and pressure points hoping they'll work first. Those techniques have little evidence behind them for severe bleeding, and time spent trying them is time a tourniquet could have already stopped the bleeding. Some situations skip the line entirely. In a mass casualty event, when the environment is unsafe, when the person has multiple injuries, or when you can't get direct access to the wound, go straight to the tourniquet. One hard rule: tourniquets only work on arms and legs. They rely on compressing a limb against bone. You cannot tourniquet a neck, chest, or abdomen. Those wounds need a different technique, which we'll cover shortly. A commercial tourniquet is a wide strap with a windlass rod that twists to tighten. If you don't have one, an improvised version needs to be at least 2 inches wide. Never use rope, wire, or a thin cord. Place the tourniquet high and tight, 2 to 3 inches above the wound, never directly on a joint like the elbow or knee. If you're not sure exactly where the bleeding is coming from, place it as high on the limb as possible. Pull the strap tight, then twist the windlass rod until the bleeding visibly stops, and there's no pulse below the tourniquet. This will hurt. That pain means it's working. A tourniquet that doesn't hurt isn't tight enough. Lock the windlass into its clip, secure the strap, and this step saves lives. Write the exact time on the tourniquet itself, on skin or on tape. Medical teams need to know how long it's been on. Once it's on, leave it on. Do not loosen it, do not check on it. Do not remove it to see if the bleeding stopped. That was old advice, and undoing it can restart catastrophic bleeding and cause more harm than leaving it alone. If bleeding continues after the first tourniquet, apply a second one just above it, closer to the torso. Then get the person to a trauma center, ideally within 2 hours, where surgeons can address the injury properly. Now, what about bleeding a tourniquet can't reach? The neck, the shoulder, the groin, or deep inside the torso? These junctional wounds need a completely different technique: wound packing. Take gauze, plain or hemostatic if you have it, and pack it firmly and directly into the wound, right against the source of bleeding, not just laid over the top. Then, hold hard, steady pressure directly on that packed gauze. Hold that pressure for at least 3 full minutes without letting up to check. Hemostatic gauze contains an agent that speeds clotting on contact, but it only works if it's actually touching the bleeding source, packed deep into the wound. For bleeding at the groin or armpit specifically, a specialized junctional tourniquet can compress the vessel where a limb meets the torso. Most homes don't have one. Packing and pressure are your realistic tool. 2 exceptions worth remembering: never pack gauze into an open chest wound, and never remove an object that's impaled in the body. Pack and pressure around it, and let surgeons handle the removal. Myth 1. A tourniquet means you're going to lose the limb. False. Properly applied tourniquets, left on for under 2 hours, rarely cause lasting damage. And military data from Iraq and Afghanistan shows essentially no limb loss from tourniquet use itself. Myth. Myth 2. Loosen the tourniquet every so often to let blood flow back in. This used to be taught. It's now known to be actively dangerous. It lets fresh bleeding restart and can push clots into the bloodstream. Myth 3. Tourniquets are a military tool, not something regular people should use. Wrong. That's exactly why Stop the Bleed exists. Everyday bystanders using a tourniquet in the first minutes save lives. Paramedics can't reach in time. Myth 4. Direct pressure is always the safer choice, so always try it longest. For truly severe bleeding, the safer choice is whichever one stops the blood loss fastest. And often, that's the tourniquet. Who actually needs this skill? Anyone near power tools, kitchen knives, car traffic, hunting or hiking trails, or a workplace with machinery. Severe bleeding doesn't wait for a hospital to be nearby. It happens in garages and kitchens every day. For children, the same principles apply. Direct pressure first, tourniquet if it's not controlling the bleeding, just placed with the same 2 to 3 inch clearance from the wound on a smaller limb. Don't hesitate because the patient is small. Quick recap. Expose the wound. Apply firm direct pressure. And if it's not enough, spurting, soaking through, or inaccessible, go straight to a tourniquet, high and tight, write down the time, and don't take it off. We've built a free, printable bleeding control checklist at firsthour.com. That's the video. If this made you 1% more ready to save a life, hit subscribe. We post one of these every week, and share it with whoever keeps a first aid kit in their car. This is First Hour. Be ready for the first hour.